and I was given another task to read the citation and the introduction of our keynote speaker, Professor Sir Sabaratnam Arulkumaran. Professor Sir Sabaratnam Arulkumaran is a world-recognized, truly Sri Lankan figure, and we have to be proud about himself and his achievement. He is very kindly accepted my invitation, and Dr. Rohana Hattatuwa helped us to do a lot of work to bring him to this stage, and thank you very much, sir, for your support. And Professor Sir Sabaratnam Arulkumaran is a world-renowned academic in the field of obstetrics and gynecology. I told you he is a Sri Lankan. He studied in Jaffna Central College and the Mahajana College, Telipele. After his formative years, he got his undergraduate education in the Faculty of Medicine, University of Colombo. There, after the graduation with second-class honors, he moved into National University of Singapore. There he has done the groundbreaking research into the CTGs, and he is expert on these CTGs and done international service to the mankind through his wisdom and the research and the knowledge. After that, he was moved to the University of Nottingham, and there he was the professor of obstetrics and gynecology. From there, after acknowledging his talents and his contribution to the obstetrics and gynecology, he was appointed as the professor in St. George's University Hospital of London. Then, after doing a lot of research and a lot of publications and writing books, and he has done a remarkable service to the human kinds and the groundbreaking research into this CTG and the delivery of sick babies and a lot of things. There are a lot of things I have no time to do that. After that, by recognizing his work, he was appointed as the president of the Royal College of Obstetricians and Gynecologists to honor his service. Then he has served his terms and he has done a lot of achievements, and we are proud of that because he has helped Sri Lanka College of Obstetricians and Gynecologists while on there and even after that. Then to recognize his service, he was knighted by the Queen Elizabeth, and this is the London Gazette published in Friday, 12 June 2009 during his awarding knightship. So he is addressed as Sir Sabaratnam Arulkumaran after that. Then he was moved into another step, and he was the president of the Federation of International Gynecology and Obstetrics. For his term, he has done a tremendous service to this organization. After that, he was again, after completing his term of office, he is doing wonderful service to the academic circles, both in Sri Lanka and international arena. May I invite Professor Sir Sabaratnam Arulkumaran for delivering his keynote speech.
Good afternoon, and after that introduction, I don't know whether it's me or someone else. Dr. Aruni, Pram, Indrulal Silva, Sanath, thank you very much for inviting me. So I'm going to take you through a journey about how to implement policies or how to advocate for policy change in sexual and reproductive health. So first, Sanath, thank you for inviting me to give the talk. So it's going to be a little bit of a personal story as well as the issues related to sexual and reproductive health. I had no particular interest in giving this talk. So the way I have structured this talk is actually what are the principles we follow in terms of establishing women's sexual and reproductive rights. First of all, we have to think about how the faculty or the profession in social sciences, medicine evolved, and they were champions who established ethical principles. Second, I will touch on what do you really mean by sexual and reproductive rights of women? Why is there a special emphasis? Why not men's sexual and reproductive rights? Case examples I'll take: rights to safe birth, rights to safe abortion, which is very controversial as mentioned by Professor 𝐀𝐝𝐲𝐬𝑬. So we'll touch on that. Rights to postpartum contraception or any contraception, and concluding remarks. So to start with about ethical principles, if we go back in history, there were 7 figures in the history of Western philosophy on medicine who helped us to shape and fulfill the commitment of social sciences, medical sciences with dignity and integrity. The practical application of the ideas on ethics resulted in essential contributions as to how we understand and implement our professional duty. So these are the 7 people. They contributed in different ways. Originally, in the medical world, Hippocrates from Kos in Greece was a barber, because the profession of medicine evolved from a barber. So we are all barbers. We sit in the marketplace, remove sebaceous cyst, and so on, and became doctors. But the following people, Plato, Aristotle, John Gregory, they all shaped how we should practice medicine, also how the professional organization should help in developing policies to help humankind. Say, for example, Aristotle was emphasizing on justice. In general, the ethical principle of justice requires that everyone receives his or her due. So not differentiating somebody poor getting poor care, rich getting some other care. So if the condition is the same, then we have to treat them equally with compassion and care. If we take Plato, he was talking about beneficence, which means we had to commit ourselves to a life of service to fellow citizens. So we can't say, once you want to practice social science or medicine, you can't say, I have no time. You have to give your time in order to establish that. And John Gregory contributed quite a lot, because he talked about beneficence, non-maleficence, and autonomy. Autonomy of the individual to decide what they want and what they don't want. So if there's someone cancer, don't want to have treatment, that is their autonomy and they must give that. So in basic principle, it commits himself or herself to scientific and clinical competence, makes the protection and promotion of the patient's interest as primary consideration, not the money they are going to get, but the service they provide. So if you take any newspaper in any country, Sri Lanka, England, anywhere, every week there is something about doctors fleecing somebody for something done wrongly and so on. So that principle has to be followed, that we give the best interest to the patient as the primary considerations, and make protection of self-interest a systematically secondary consideration, which we call as ethical practice. Now, Thomas Percival said how the organizations like the Family Planning Association, maybe the Sri Lankan College of ONG, how they should behave in terms of providing the best medical or social care, because they have to really regulate the practice, training, and philosophy behind practice. So it defines organizational professionalism in response to disputes among medical and surgical staff that threaten to paralyze the organization. So no fighting between groups or subgroups, and to give the best. And defines the organization in response to rationing of hospital resources. If the hospital cut down the budget, how do we put certain aspect to something? And the typical example is the national budget for sexual and reproductive rights. If they devote a lot of money for health, vast amount will go to the old people who have cardiology problems, like the ministers and senior figures, but very little will go to the youngsters who need contraception or other things. So how do we balance that? That was mentioned by Thomas Percival. So we will go to these simple principles of beneficence. So it's defined as supportive and individualized, evidence-based practice. Practice is proven to be beneficial. So beneficence is beneficial. And you can take an example of childbirth and how we give respectful care for women in childbirth. And we go to non-maleficence, not to do any harmful practices, because in gynecology, for example, it's not that uncommon. They do a scan and find a marble-shaped fibroids, and they want to do a laparoscopic surgery, which is totally unnecessary. And not only they fleece the money, but also put the patient to have complications. So how do we really regulate our profession to avoid procedures that have insufficient evidence of benefit and avoid disrespect and abuse? Don't shout at patients or clients who are coming to you. Then of justice, we have to treat them with respect, dignity, and informed choice. Sometimes there might be 3 or 4 alternative choices available. We don't express all that. We just express only 1 or 2 that fit us, and then we forget. So that is quite abundant in sexual and reproductive rights. For example, if you go to the gynecological ward, obstetric ward, how many of us talk about contraception for this individual, taking that whole individual and not focusing on the single disease for which they came? So we are lacking in our principles of justice for not giving enough knowledge to look after the whole person for the future. And autonomy is to listen to the woman and families and communicate health knowledge and information so it can be culturally safe and sensitive manner. And ensuring her right to informed consent and refusal, so she can. Sometimes we go, as a pregnant mother, she wants an induction on labor. If there are no reasons, you have to explain. And similarly, we might force ourselves to induce or do an elective section, so which is wrong. So something which we have to make a joint decision as to what is best for the individual. Now, we talk about sexual and reproductive rights. I want to bring the words of Professor Mahmoud Fathallah, who is well known to Pram, and they have worked together. And he was the former president of FIGO, the International Federation, who comes out with wise words. And he said, sexual and reproductive rights are not new set of human rights. They are simply the application of the already recognized list of human rights to the areas of sexuality and reproduction. And few members see firsthand how women's health is often compromised, not because of lack of knowledge, but because of infringement on women's rights. Now, he emphasized this, that it is a layer over the existing human rights, because women face more consequences throughout their life. Infancy, there are sex-selected abortions, before even they are born, genital mutilation, discriminatory nutrition. Adolescents, they have early childbearing, unsafe abortion. Reproductive years, they have sexually transmitted infection, malnutrition. And post-reproductive years, they have similar problems. They are more prone to cardiovascular and gynecological cancers and so on, and lifetime problem of gender violence, occupational and environmental hazards. So I see Dr. Lakshman Sennak here, he's a champion on gender-based violence, so that is something which we have to do, continue to do, and it never stops. 1/3 of women are physically abused, 2/3 physically, verbally or mentally abused. So we have to get rid of that, and we have to put a set of standards to protect this from women. So women have special problems because they have to have menstruation, they have to have pregnancy, they have to deliver, post-delivery problems, and if you ask for contraception, the men run away, the women have to take the contraception. So we have to make sure that we provide the best. And I'm glad Rowan Arthur brought the Asia Oceania Federation here today, and they would be champions of this. So if you take the sexual and reproductive rights from old days, in India there was a custom. A very young woman is married to an old man, and the man dies, they push the woman into a fire called sati. Now that has stopped. So that's sex-selective abortion still goes on. Female genital mutilation, millions happen in sub-Saharan Africa. Honor killing and so on. So I'm going to take 3 areas: rights to appropriate contraception. What do we really mean by that? Are we giving, and can we improve that? And then I'm going to talk about rights to abortion. It's a very emotional, abortion is a human drama because there are emotional, ethical, legal issues. So how do you navigate? In different countries, it got to be different. You can't have uniform policy for all countries, and I will give you some example of how to navigate the rights to abortion. And right to life, to means to have, because a woman performs a noble function of having a pregnancy and giving birth to a child for the sake of the family, for the sake of the country. So we have to do our utmost best to keep her safe and give the best of care. So how do we really establish the rights to life? Because that is also part of sexual and reproductive health. And rights to avoid STI. Mainly it is tackled by education, nutrition, healthcare. But I'm going to specifically take 3 areas: contraception, abortion, and rights to life related to pregnancy, giving some example where I was involved. So this is a paper I did in 2012, Saving Mothers' Lives Transform Strategy into Action, which Dr. Sanath Lalnaral mentioned. No point having policies unless we really execute that. So this booklet, which was produced for Institute of Global Health, for national non-governmental organizations, professional organizations, governments to act in order to reduce maternal mortality. Essentially, when I did the analysis with the team at that time, it was clear that there are 3 baskets of care which can save the woman's life. The first basket is contraception. So although it is away from pregnancy, unless they have contraception, they are going to die. Because if the woman gets pregnant in England, she has a 10 per 100,000 chance of dying. If she's not pregnant, she won't have the chance of dying that way. In Sri Lanka, it's just under 30. Some countries, it's 300 per 100,000. So contraception will reduce maternal deaths by 30% if we can give contraception to everybody who needs it. Safe abortion care can give rise to 15%. Because where it is legally allowed, we have to think about abortion, not criticize, because people say you're an abortionist. I say all of us are abortionists. I might support legal abortion. By not supporting the legal abortion, you are supporting illegal abortion. So they will get into problems of infection, death, and so on. But based on a calculation, 15% of lives can be managed, prevented by safe abortion care. Emergency obstetrics, which is postpartum hemorrhage, preeclampsia, is about 55%. So the Sri Lankan College and the Government Family Health Bureau, they are doing their best to avoid that. So these are the 3 baskets of care which we have to focus to avoid a maternal mortality. So I'm coming to a real life story. This is a hospital close to London, or just north of London, called North Fig Park Hospital. It's a big hospital where they delivered 5,000 odd cases each year. And during the period 2002 to 2005, there were 10 maternal deaths in 3 years. 10 out of 15,000. The standard in UK is 10 per 100,000, but 10 happened in 15,000. So they are desperate, and the report came out, and the minister at that time rang me and said, you have to go and sort it out, because otherwise the Healthcare Commission is going to close the hospital. And if they close the hospital, 5,000 women will have to go to some other hospitals for care. So we went there and introduced clinical governance, which I will explain in a minute. And these are 2 figures I am giving you. One is a nurse from Philippines who was working in the hospital. She died after childbirth following C-section due to hemorrhage. The other one, a Sri Lankan woman whose sister was a doctor in the hospital, and she was saying, I'm breathless, I'm going to die, and she died because not adequate care was given. So there are 10 deaths like that. So once I went there, I had to challenge the consultants who are working. 2 consultants were suspended, 2 asked to leave, 1 was transferred from their board duties. So those are difficult decisions against my colleagues or professionals to take. But I had to take it because otherwise this thing would have continued and more deaths would have happened. Because we had to think about the women based on the ethical principles I told you. We had to give our best. And the answer, once I got rid of 4 of them, was to find new staff to come. So I recruited 3 consultants from Sri Lanka because I thought they were good. So Hemantha Sennaka was there already. I see the professor from Colombo. Then there was a consultant from Wadiklo and Samarage from Gaul. So I said to come with another consultant from Australia, Alda Baka, and help me to organize, because suddenly 4 consultants goes, I'm left with nobody to work. So we managed to turn it around by introducing what we call as clinical guidelines. And the chief executive is Mrs. Mary Wells. She was very happy. And she said, we have turned it around in 18 months. So what we did do as a magic, because when an accident happens like that, like a train going through the bridge and falling down, there are a number of reasons. It can be failure of brakes, it can be an untrained driver, he has gone to sleep or no speed check. So similarly, when clinically something goes wrong, then it could be inadequate capacity, inadequate trained staff, not proper educational courses, no proper good communication and teamwork, and no guidelines of how to manage. Patient complaints are ignored, and there are no risk management principles. So these are 7 of these principles for clinical governance. So I had to establish, and I told the chief executive, we had to introduce clinical governance. I went and stood, she couldn't understand, so I said, look at me, right arm, left arm, and these are the things we are going to do. So when we come to services, we didn't have enough midwives because they were all running away because the workload was high. So I had to go to the local council and ask them for salaries of 20 midwives. So they said, how sure are we by giving you the money you are going to save women's lives? So I said, you value your women and say, how much is your woman worth in your council? And give that amount of money and we will cater the services. And introduce evidence-based guidelines, education and training, and audit. And I got hold of midwives from other hospitals, matrons from other hospitals to look into the complaints. So it's not a simple process, but you need a lot of support and help and collaboration to bring about the change. So, for example, this is a table of maternal deaths. If you look at the 4th column, or 5th column, the lack of consultant obstetrician input. So the 10 maternal deaths, 6 deaths happened without a consultant seeing her, which is pathetic, because if you think your wife or your sister or mother goes in, and if you say the senior doctor didn't see and she died, that's disgraceful. So that's what happened, 6 out of 10. One of the problems was the juniors did not know when to inform, so they didn't inform, or the nurse didn't inform. So I introduced this early warning score chart. So forget about what is the exact pulse, blood pressure. You put it on the chart, and if one goes into red, then you inform the consultant to come down. You don't have to give an explanation, you come down. This is used in disciplines in medicine. So we adapted it to the obstetrics because they can have a high blood pressure due to preeclampsia or low blood pressure due to postpartum hemorrhage. So we modified and adapted it, and that was useful. And to monitor how things are working, we must know every month what is happening, how many women are getting admitted to ICU, how many are getting blood transfusion. So I introduced what we call as a maternity dashboard. Maternity dashboard is like a car dashboard. When things are going wrong, it'll warn you. So it's like the petrol going down, you don't bother about it till it goes to red. Then suddenly you start sweating and your bladder starts filling up, and then you're rushing. So if you keep that, the parameters of the workload, I'm sorry, it's all small letters, workload, how many normal deliveries, how many C-section, forceps, admission to ICU, blood transfusion, complaints, and review that on a monthly basis, then you know where to pay the attention, where to spend the money. So that helped in many ways to overcome the problem of maternal deaths. Now I mentioned there were 6 cases where the consultant didn't see, and I went through the confidential inquiry into maternal deaths, which comes out every 3 years. And there again, these are a large number of deaths in the UK, 70% maternal deaths because of suboptimal care. And many of them are due to consultant being not present or informed. So I became president of the college, and the first thing I did was to produce a paper on responsibility of the consultant on call. That means they should be there when there is a postpartum hemorrhage, eclamptic fit collapse patient. And we tried to reverse the whole process. And of course, I got challenging death letters saying, who are you to tell us what to do? But I said, this is not going to change, because unless we change it, it's not going to happen. So I reviewed the figures in the confidential inquiry in 2022, and the 75% has come to 45%. Still, there's suboptimal care in 45%. But nevertheless, we are making steady improvement. Now we go to the subject of human drama about the abortion. The rights to have safe and legal abortion has a lot of issues about the ethical, legal, and moral issues. And unsafe abortions is one of the leading causes of maternal mortality. Now we can prevent this unsafe abortion if they give effective contraception for those who want before they get pregnant. You can think of emergency contraception, you can think about postpartum, and post-abortion contraception you can prevent. But then if it is morally or ethically not acceptable, then you can think which section should have abortion. Not everyone, but some section. Now this is quite important in terms of some countries, and this is England, Ireland. In Ireland there was always a debate, and this is the example produced by the church in 1983. A way to protect Ireland for good is actually not to allow abortion. The state acknowledges the right to life of the unborn and with due regard to the equal right to life of the mother. So even if the baby is 6 weeks, if the mother is sick, she can't have an abortion done. If the baby cannot survive, it has severe chromosomal abnormality, still you can't have an abortion done. So she has to carry, sometimes up to full term, everybody asking, how is the baby? You have to say, it's okay, but you know the baby has no head. And then carefully you carry on till term. So she has put under severe pressure, and we had to think about what was going on. So this was going on for decades, and whenever they called a referendum whether to modify the abortion laws, 1/3 said no, 2/3 said no, 2/3 said no, and 1/3 said yes, we had to modify. And the yes, 1/3 are young girls and young mothers who have problems socially, medically, ethically, and so on. And it is important to remember that 1/3, despite the church influences, said they want to change what is known as the 8th Amendment in the law. And a tiny group of volunteers were working, they were trying to influence the church, but they couldn't do much. So this is the type of scene in the referendum in 1992. They brought another referendum to tighten it because somebody did abortion for mental health problems. Another one did for the mother having malignancy. She went to the hospital. At 18 weeks, she was having chemotherapy. Because she didn't have periods, they thought it was due to the chemotherapy, but she was pregnant. So then she died, but they kept her ventilating for till 23, 24 weeks, using her as a reservoir, a tank, to keep the pregnancy going, to receive the baby at 24 weeks. And there's a dead person without any proper, the heart was beating, but she was completely gone. So that type of things happened, and the referendum was going, and the Irish Family Planning Association was a central key to change the law and to canvass. These are different pictures. And what happened for reason for resistance in Ireland, unable to access to abortion, what they did was Britain and Denmark and Holland allowed abortion. So they took the flights from Ireland, especially if they had sex out of marriage and a pregnancy, and they went. But those who could not go, those are the poor ones, stayed behind in Ireland, and they were sent to the church, to the nuns' seminary or whatever it is. The heads were shaved, they were given jail uniforms carrying a pregnancy, and they were asked to scrub the floor and to do the work. They called them Magdalene laundries. And it was estimated that 35,000 women were forced into this institution, and 6,000 babies died in their care, because once the baby delivered, nutrition was completely a different thing. They changed the names of the babies and adopted to families in Australia, USA, Canada, and so on. So this was going on, not in one part of Ireland, but the whole of Ireland. And these are the girls. The second picture with the goddess there says that that was a graveyard found in the compound, and they recovered bodies of young children. And so not only is this, there was a protest because of that, and they were adopted, as I say, thousands of babies were sold exported to US and Australia. And so the mothers, when they wanted to see the baby, they were not available. So which part of the justice are we going to uphold was the question. So this is a picture. They take the bag, go to England, get the abortion done, and come in the same evening. Now, because they go there to have surgical abortion, so when they come back, if they bleed, then there are no chance of getting into the hospital. If they go into the hospital, they'll be arrested and put into the jail for 13 years. So it was a radical problem for the mother, and balancing was a difficult issue. So in the clinics, in 1980 was 3,320, then it rose to 6,673 because abortion or abortion-related topics were declined. So the Family Planning Association of Ireland took 3 cases to the European courts. One was because she was physically ill, one she was mentally ill, and third, she had suicidal tendencies. And the European court said, these women, according to human rights laws, they should be permitted to have abortion. Although the verdict was given by the European court, the Irish government and the hospital did not want to do it. So whatever they did was a problem. Now, while this struggle was going on, there was an Indian dentist in a city called Galway, and she had a 19 weeks miscarriage. She went with bulging membranes, and then the membrane ruptured. She had striking fever, chills and dry gauze. But they kept the pregnancy going because when they put the doptone to listen to the baby's heart, the heart rate was present. So they said, I can't do an abortion. The chance of a baby surviving at 18 weeks ruptured membranes is about 0.5 to 2%. But they kept her going despite a pulse was 160 at high temperature because there was a fetal heart present. So there was a problem there because she's going to die if it is not done. You can't treat sepsis without evacuating the uterus. She died anyway of septic abortion. And then there was this protest in the roads of Ireland saying that never again, and this should be stopped. And there was a public outrage saying that if they are medically indicated, at least, if she has sepsis, heart disease, severe renal disease, it should be allowed. So it so happened, they rang me and asked me to chair the inquiry and see what could be done because this woman had died. They didn't trust a local Irish doctor because they would take sides, so they wanted somebody neutral. So I went to Ireland, and there were people who wrote and in the papers said, I'm a pro-abortion group, chairman of the FIGO, is called the pro-abortion group, and asked me to be removed as chair of the inquiry, but the government insisted that I should continue. And I came out with the report and suggested that they should change a lot of medical recommendations, but also they should change the abortion law. So the abortion law was confusing. The legal status need to be addressed. And the Minister of Health asked me to give us a report, which I presented. And 6 years, nothing happened. So we had to go and mobilize the professional organization, the Irish ONG Society, the Family Planning Association, Citizens Group. So with a lot of small group protests, the government organized a Citizens Bureau, 100 people with different walks of life, lawyers or doctors, teachers, and asked us to address and see whether they can come to a consensus. So I started a questionnaire for them and said, would you provide abortion if there's a physical risk to life? Will you say if there's a risk by suicide, serious physical illness, serious mental illness, and so on? So that is marked in green of those who agreed yes. So for physical risk, almost 99% said they will provide abortion services. But for no reasons, only 64% supported that, and up to 12 weeks. So this was quite a useful plate for us to take it to the Irish Parliament. So the Citizen Assembly voted, and 64% of members also voted that abortion should be made legal on women's request. So this is a very controversial issue. And after agitating, the Parliament convened a parliamentary group in September 2017. So I was asked to go and give evidence. They called evidence from Irish doctors, various walks of life, social care, everyone. And they finally came to a conclusion about having a referendum. So If you go into the Google and put my name, Arulkumaran in Ireland, you get all these videos. I want to spend time with you. And the referendum was done, and 66% of the population voted the abortion law should change, because so many women are dying, so many women are losing, so many mothers don't know where the children are because they are given on forced adoption. So that is the second story about how to establish the rights of women. You can't just stay, you have to agitate with small groups and see what is best for them. Because otherwise their children were dying, they were kept like prisoners, working in laundry, other children were adopted. Now we'll talk about contraception. Now as a house officer or senior house officer at Castle Street, my long commentary for the 𝐀𝐝𝐲𝐬𝐬 exam was 2,000 cases of postpartum sterilization in 2 years. I thought I was a champion. But what I was doing was wrong, because we didn't have any other methods of contraception at that time. The lip peace loop was just emerging at that time. And they said if you put it in, it'll perforate and go into the baby's brain. All sorts of talks. And the women who were having this sterilization were young. They were 20, 25. And if some babies die, then there are no this thing. And this map shows 1994 to 2024. The women are the ones who get sterilized. The men don't go to the scene. So this was a major problem, which was something to be done. And you go to India, Bangladesh, it's the same thing. They have camps. So there's a surgeon who goes from bed to bed, putting a laparoscope and putting the clips on. They do 300, 400 sterilizations a day. And there was a myth about having IUCD that it'll fall off. And when we had the meeting at the Sri Lankan college, they said 3 women or 4 women had IUCD put in postpartum. By the time they went down the lift, all 4 on the lift or something like that. So it was a problem. So we were thinking about it. Then the wake-up call was tsunami. During the tsunami time, there were a lot of mothers who lost children, 10 years, 12 years, 15 years, but they were all sterilized, so they didn't have children. Should we have a long-acting reversible contraceptives, we could have prevented the problem. But we sterilized them, and we didn't have any opportunity to do something. So we got together at Sri Lankan College, and we sort of brainstormed. And from Nine Wells Tea Room, we gave a call to the donor, and we got some funding to change the picture from tubal ligation to postpartum contraception by an IUD, because an IUD is a few cents, and it can be kept for 10 years. If they want to pull it out in 2 years, they can go for it. The two concerns were infection and expulsion. So we said we will train them, because if you put it to the fundus of the uterus, and it won't fall off. Only about 2%, 3% expulsion. And 2%, 3%. This is with the donor from Buffett Foundation, with Rowana Chandrikan, the then health minister. And we were training in Kandy, Nepal, Tanzania, Kenya, 6 countries we did. And we did about more than 60,000 cases, and all were documented with researchers going and making a note of everything. And the expulsion rate was 2 to 5%. And infection rate was less than 1%. So if you can put it within 48 hours in the right place, in the right way, you can. So in many countries, they made it a national policy. In fact, the Family Planning Association, Family Health Bureau, went to the minister and got it circular issued that postpartum long-acting reversible contraception should be offered in Sri Lankan hospitals. So now they have reversible with IUCD and implants. So I think influencing policy to empower women's sexual and reproductive rights is based on ethical principles of beneficence, non-maleficence, autonomy, and justice. And saving lives focused on 3 baskets of care, which I discussed. One was about safe obstetric care during childbirth by introducing clinical governance, rights to abortion by mobilizing women's associations and professional groups, and rights to contraception by implementation clinical trials. And any field we take, whether we are medicine, social services, academics, we have to think about these 7 C's. Commitment to the profession of patient care or anyone you are giving. You have to be compassionate, courteous, competent, good communicator, confidence, and coordinate the team, because we provide services whether we are in social care, public health, or medicine as a team. So we had to build the team, and each one of us had to follow these 7 principles. And based on the proposals or the prognostication for women's and sexual reproductive rights to become norm, it'll take a long time. If you take South Asia, it'll take another 195 years. So how can we accelerate that? Make the women as equal in terms of salary, in terms of holidays, in terms of schooling and so on. We need to. And part of the issue is the men do the policies for the women's health. So unless we, men and women, partner and empower the women, it is not going to happen. So I'm glad that you have a mixed audience of men and women, and your journal, Dr. 𝘗𝐿𝐶𝐿𝐽𝑎 and Sanath, will catalyze men and women working together. In other words, we are asking women not to push us out. We are going to be part of you and to help. I saw this being sent to me just a few days ago, and it attracted me. I don't know the author, but the author's name was there, so I like to acknowledge. This is a woman carrying the washing machine, cooking utensils, brush, everything, and taking the two children. So this is not merely a statue, it's a symbol. Powerful reminder of the countless women on those shoulders our society quietly rests. And this service is invisible, they are sacrificed daily. They allow us for nothing in return, so they don't ask anything in return, they do the services. And yet, without them, nothing would stand. And it is not merely an act of gratitude, but a moral duty toward those who perform those vital functions and too often forgotten work in the world. So I hope your journal will be reflecting this, that you give and respect every single woman and establish the rights the woman should have. It's not easy, but it is possible. And this picture shows it is possible. This is the word women and children first came from this picture. This is a ship, Birkenhead, sailing from South Africa. And the boat sinks, and the captain orders women and children first to the lifeboats. Captain and crew stood on board, and they were playing the music to soften the mood. And this is an act of professionalism, chivalry, and this is the ethical principle we have to follow. And of those on board, 193 of 643 survived, the others sunk. But the principle was established, the men should take the responsibility and take the courage to stand for women. So I would like to give my best wishes to the Family Planning Association, part of IPPF, and for the launch of the Journal of Sexual and Reproductive Health. Thank you very much. Indeed.
Thank you very much, Professor Sabaratnam Arulkumaran, for that insightful, eye-opening address with real-life examples that truly highlighted how important it is that we pay more attention to this subject. So, ladies and gentlemen, shall we put our hands together for Professor Sabaratnam Arulkumaran? And of course, we would also like to thank Professor Sanath Lanaro for sharing his valuable perspectives with us earlier. Thank you very much, sir.